Hi, and welcome to our show, Bridges to Community. My name is Sarah Turcotte, and I'm the Area Community Liaison for Bridges by Epic.
And my name is Erica Lab, Executive Director at Bridges by Epic in Westford. We have a very special guest with us here today, Dr. Brent Forrester. Welcome, Dr. Forrester. Dr. Brent Forrester is the Chief of the Division of Geriatric Psychiatry at McLean Hospital, Medical Director for Behavioral Health Integration in Primary Care at Mass General Brigham, and an Associate Professor of Psychiatry at Harvard Medical School. Dr. Forrester is an expert in geriatric psychiatry, specializing in the treatment of older adults with depression, bipolar disorder, and behavioral complications of Alzheimer's disease and related dementias. He is currently president of the American Association for Geriatric Psychiatry and a distinguished fellow of the American Psychiatric Association. We are honored and thrilled to have our friend, Dr. Brent Forrester, with us today. Welcome.
Thank you, Erica. Thank you, Sarah. It's so great to be here.
Great to see you. So we wanted to first just start with kind of the thing that's on everybody's mind, which of course is the pandemic. And we'd love to hear from you how the pandemic has really touched the lives of your clients and the families of the clients this year.
So thanks again for inviting me to do this. It actually today marks just about the 1 year mark since the state of Massachusetts declared a state of emergency for the pandemic. And it's hard to even imagine looking back what we've all been through. And I think the older adult population in particular has been dramatically affected. So I kind of want to talk about this in terms of both what's been hard and challenging, but also some of the silver linings. So I think the stuff that's been difficult, which I think everyone is aware of, is that this particular pandemic and this virus impacted older adults specifically in terms of their risk for poor outcomes and death. And in particular, what we've learned is that the older adult population with dementia has been especially challenged by this virus. If you look at the statistics in the United States, over 42,000 people with dementia died this year, above and beyond what would normally be expected from this lethal illness.
Wow. Because
of the pandemic. That's nearly 1,000 extra people per week with Alzheimer's disease succumbing to this illness. And it wasn't just because they were in long-term care facilities, and it wasn't just because of their age. There was something about the illness itself. So that's been one really, frankly, challenging and traumatic aspect of this pandemic. It's affected older adults in terms of their inability to be with loved ones, which is true for all demographics, but in particular, older adults who are either widowed or live alone, which is often quite common, or even live as an older couple. They've had less access to their families. There's been more social isolation and more stress related to that than they would normally experience. The other thing has been the flip side to that, which is that we've seen, if you look at the CDC report that came out in August with some updated numbers just from February, if you look at the demographics in the United States in terms of rates of anxiety, depression, stress-related disorders, and suicidal ideation, to break it down, ages 18 to 25, by far and away were the worst affected group. The numbers of anxiety and depression, percent of people with anxiety, depression, and stress-related disorders, was nearly 60%, more than 1 in 2 in that 18 to 25-year-old demographic, with more than 1 in 4 contemplating suicide.
Oh my gosh.
Unbelievable.
Shocking.
If you look at people 65 and above, those numbers are dramatically less. It's in the 5% range or 10% range for depression and anxiety, and the less than 3 or 4% range for thinking about suicide. So one may say, well, why is that? So it seems sort of counterintuitive, especially when the death is higher and the isolation is more profound. And I think it's probably related to many factors, but one of the factors that we've been very interested in is this concept of resilience and the personality trait of wisdom that older adults have. And older adults in this cohort 65 and above have been through a lot in their lives. They've had other traumas in their life. They've experienced loss before. They've had disappointments before. They've been through challenging times. They've learned to cope with them, and they've gotten through them. And so their perspective about what's going on now is that it's going on now and this too shall pass. Whereas the younger adult cohort, everything is supposed to be great and they're invincible and their future is ahead of them and their life is really all about their social networks, and now all that's thrown into chaos. So if you think about it that way, it's not terribly surprising. And some people are better than others, even in the older age cohort, in terms of their personality, style, and characteristics that allow them to cope with some of these stressors. One of the most challenging and trying parts of the pandemic, though, for older adults has been inability to be with loved ones during the time of death. It's been, you've seen this, Erica, too, where you work, but especially in long-term care settings and in hospitals where until just like this week, there was pretty much a ban on any visitors for a year.
Right.
And so there were a lot of people dying alone. And that, I think, will be the singular tragedy that a lot of folks will have a hard time getting over. I think there's a lot of guilt that people feel that they weren't with their loved ones at the time of death. And the burden this is placed on the staff, the medical care staff, the frontline staff, the nurses' aides, the nursing assistants, the nurses, the social workers, the doctors, everyone involved in direct care has been that I wish I could have done more. I should have been able to do more. This sort of sense of guilt and trauma and loss has been pervasive. And I think part of the challenge, part of the work that we've been doing in our field, even though we focus on older adults, is we've looked a lot at ways we can support our staff and the staff of long-term care communities in trying to deal with some of these effects.
Wow.
I can't agree with you anymore, Dr. Forrester. I mean, this last year for all of us healthcare professionals, we're doing things that we never imagined that we would be doing. We've been doing things so differently, and it has been trying. So I completely appreciate some of the facts that you bring up. And just talking about some of the programs that you have available at McLean, you have some really great programs that people can have access to. And I'd love to share a little more information, if you're able to, about your SAGE program, which stands for Successful Aging Through Group Engagement. And just kind of curious if you can talk a little bit more about that program and who would benefit from a program like this.
So Sarah, let me just say, if I take a step back and think about the range of services and where the SAGE program fits in, that might be helpful. So we have at McLean Hospital inpatient units for people who are acutely in distress, who really need help because their depression has become more severe, they're contemplating not wanting to live anymore, or they're becoming agitated and really need a lot of help. So for those acute emergencies, we have 36 inpatient beds for individuals who are suffering from severe depression, from anxiety, from bipolar disorder, or even from severe complications of Alzheimer's disease, the behavioral symptoms like agitation and so forth. Mm-hmm. But we also have an outpatient program where we follow people in both individual and group settings longitudinally. We do thorough assessments when they come in. We figure out what treatments they need, and we support them through the course of their illness and often ongoing. So the SAGE program is our group therapy program, and it's really meant to address the needs of individuals who are in two different groups. One is the group where there's more of an acute need for like more rapid stabilization, addressing the acute problems that are going on and trying to improve things and avoiding hospitalizations if possible. But there's also the group interventions that we provide for people longitudinally. They develop relationships with other group members, with a group therapy leader. And it can be really, the real goal of these groups is for both teaching individuals skills that they need to be as independent as possible, to help them have control over some of the stress, anxiety, and mood disturbance symptoms that they have, but also for them to really receive evidence-based care in a therapy setting. And what's been interesting, and I didn't talk about this for your question, is one of the biggest impacts of the pandemic is the way we deliver healthcare. So if you're living in care facility, you don't move, you're still there. But the providers who care for outpatients, especially in psychiatry, for exactly 12 months, has been virtual. Mm-hmm. We've not yet welcomed patients back into our building at McLean Hospital for outpatient care in exactly a year. And so we're providing it all either via Zoom, telehealth type of means, either video or telephone. And what's been remarkable is how successful it's been. It's not ideal, but in some ways, on bad weather days or dealing with commuting and parking, it's been very doable actually for a lot of folks. And in some ways, our groups, in particular, Sarah, with the SAGE program, have been better attended than ever before.
Yeah, we've seen that as well. Sarah runs a couple of great groups, particularly for caregivers or people with early onset dementia. And all of those groups, we've just seen this.
They've grown in numbers incredibly.
Fantastic. I mean, there's a silver lining right there for all of us.
Well, I mean, sure, you think about these caregivers that maybe wanted to attend some of these groups or programs, but because they may not have been able to leave their loved one at home or other circumstances couldn't get to these offerings. So, I do think it's been a great way of keeping in touch and connected with one another, but also giving this opportunity to people and families who couldn't get out as easily, for sure.
You are watching Bridges to Community.
At Bridges by Epic, we focus on helping and supporting families and people living with dementia and Alzheimer's.
We have educational programs and support groups free of charge to everyone in the community if you need support caring for a loved one at home.
We solely focus on bringing quality of life and joy, as well as support to family members. Many of our programs, which were once held in person, such as our caregiver support group and caregiver education, have all been brought to the virtual platform right here on Zoom.
We can reach you and your loved ones in your home, so you don't even have to leave the house to get support. Hopefully, you'll get a lot of support from our show, Bridges to Community. You can watch old episodes, and believe me, we're going to have more coming your way, so stay tuned.
Thank you so much for tuning into our show, and we look forward to seeing you more this year.
Thank you.
Sure.
The other thing I would mention is there's another kind of group that we started over the past year. One of the things which I'm happy to talk more about is we run a pretty large research program, and some of the research we're doing are for people with Alzheimer's disease or early stages of dementia called mild cognitive impairment. Some of the studies involve investigational compounds not yet available on the market to help stop the disease in its tracks, essentially, removing the underlying disease burden in the brain, these amyloid plaques and tau tangles. And individuals come into the clinic here monthly for these intravenous infusions. We spend a lot of time with them. We support their caregivers. And when the pandemic struck, we had to shut that down for about 4 months. And they were used to the support and social interaction they got from even coming into these visits, above and beyond whatever the treatment was providing. And I felt really strongly about providing some type of group experience to keep them engaged and supportive during this time. So one of our phenomenal social workers, Marie, started a group one for the caregivers and one for the people with dementia. And they were very early stage, high functioning people for the most part. And it was so wildly successful that we continued them after the study started up again in the fall. And now we've expanded it. So we provide these, frankly, free of charge for our patients whose caregivers are involved in supporting their care, but also to help us engage with people with dementia, especially so that they have this peer group that we never had that before. And it's been unbelievably effective. We've gotten a number of our research assistants who are relatively young college grads who are interested in healthcare fields, participate as co-leaders in this group. We've had some students involved in it. I think all in all, it's been a really, really amazing addition. Never would have happened if it weren't for the pandemic.
That is amazing. That is awesome. Thank you so much for sharing that. And I've had the pleasure of talking with Marie, and I find that those programs are just amazing. And, we need more of them. So to continue those offerings, hats off to you guys, because it's definitely much needed.
And kudos to you, Sarah, because you've been running those programs also through the entire pandemic, and they've just been great. And the way that all of you have really just scrambled to get all the technology in place and then teach the families how to use the technology that we need. I mean, that was a big transition, and people really worked hard to get that together quickly. And here we are a year later, and people are logging on and getting in the chat rooms and learning how to connect post meetings. It's really been Amazing.
And even connecting with other caregivers who are in the same boat as they are, that they would have never have had the opportunity to connect with. I mean, our early stage support group runs, for people here in Massachusetts as well as Connecticut and New Hampshire. And there's families and memory impaired people who are connecting with one another outside of these groups. And, providing those opportunities is definitely much needed. And we're so proud to absolutely be a part of that. And I also, Dr. Forrester, some of your other outpatient offerings, could you talk a little bit to our audience about the memory disorder assessment clinic that you guys offer at McLean?
Sure, Sarah. So our memory disorders assessment clinic, we've had a memory clinic in McLean now for decades. Over time, it's evolved a bit, but basically, we get referrals from primary care clinicians who have patients who may have some memory complaints or may have known cognitive disorders, but they need a further assessment. We get referrals directly from people themselves who are worried about their memory as they've aged, or they're worried that they've got a family history of a loved one who's developed Alzheimer's disease, or they are being referred by their loved ones who are concerned. So we get all sorts of different kinds of referrals. And essentially, we have a team that represents different specialty areas. So when, you could go see a neurologist for a memory problem, you could see a psychiatrist, you could see a neuropsychologist, you could see a neurologist or a geriatrician. And it's very confusing, frankly, for families, like, where do I turn next? So we kind of put all those people together in one team. And so you come in and you get evaluated by a geriatrician, in our case, who's an older adult specialist who does a good history, a physical and neurological examination, and does a basic test of memory and attention and mood. And then we decide, what do we need from there? And so oftentimes people will go through a battery of more detailed cognitive tests to sort of identify both the strengths that they've got in terms of their brain function, but also the areas and opportunities for improvement. We put people through sometimes brain imaging, where we get an MRI scan to see if there's anything going on in the brain that could be causing some of the memory problems we're seeing. We assess if anyone's been on medicines. Are there new medicines that they've been started on that could be causing the memory problems? Or maybe they're drinking too much alcohol, or maybe they've been prescribed a medication by their regular doctor for sleep anxiety or some other medical condition that actually causes significant memory loss. So there's so many possible causes of memory loss that we try to sort out. Another big cause is, other medical problems that masquerade as a memory problem. Thyroid dysfunction, for example, or vitamin B12 and vitamin D deficiencies. People take over-the-counter pills like Tylenol PM all the time, which causes cognitive side effects. So there are all sorts of things that we investigate. And then finally, we do a very thorough assessment of the family situation. What's the environment like where the person lives? How can we maximize their quality of life and their functioning? And how's the caregiver doing? Because we know that this illness is common. There are about 6.2 million Americans with Alzheimer's disease or related dementia. There are probably twice as many caregivers. And the burden that the caregivers experience is not only their own psychological distress and risk for depression, but it's their physical health as well. And sadly, we've just lost a caregiver of a patient we followed for many years who had a heart attack, completely healthy, and dropped dead, in part related to the stress of caregiving. I have no doubt in the world that was part of the problem. And I've said over and over again to caregivers of our patients over the years that if you can't find a way to take care of yourself and get the help that we're trying to help you with so that you have your time for yourself, you may be outlived by your loved one with dementia, and then what? And it's very hard for caregivers to let go. So a big part of our memory clinic is connecting with a caregiver, assessing what their needs are, and making sure that we provide for them and teach them skills they need to be a better caregiver, because this is a long journey, as you both know.
Yeah, like we always say the analogy of being on an airplane, and they always tell you to put the oxygen mask on yourself in case of emergency before you do the rest of your family. And that's like such a great analogy for what you've just shared. Another piece of what you just shared, which I think really for our viewers is so important, is that when you're exploring what the cause is for your symptoms, often you have to go to several different providers. And what a wonderful thing that you're doing at McLean is that you're looking at every single angle in one place, rather than people having to schedule literally, 8 different appointments to see what it might be. It's very comprehensive. And I think for people who haven't been through this before, that's really good knowledge to have, because something like a B12 deficiency or a urinary tract infection. I mean, these are all, it's like, it runs the gamut and it's wide. And so to get a full workup has a huge impact on the quality of life for the whole family, and being able to get some answers and then figure out what you're going to do as a family and as a caregiving team.
Absolutely.
One thing I'll just follow up on that, Erica. Sometimes when people come in to see us in the memory clinic, we're trying to sort out whether or not their symptoms are related to something like Alzheimer's disease, or maybe even a psychiatric condition like depression.
Yeah.
And oftentimes in older adults, especially who present for the first time with depression over the age of, say, 65, that may be the tip of the iceberg of something else going on, but it looks like depression first. And it's still treatable in terms of the depression, but it may signal something else going on. So part of our job, and this is a hard thing to sort out, is what's depression, what's dementia, or maybe what's something else. And the other thing I'll say is that sometimes people who have Alzheimer's disease or other dementias develop depression, or they get anxious, or they get worried, or they get agitated. And there's a lot of room for improving quality of life and day-to-day functioning in people, even when they develop some of these behavioral and psychological symptoms of dementia that are so very common. Those symptoms are common, they're treatable, and they often drive, in many ways, the burden of the disease. I mean, caregivers don't burn out because their loved one can't remember their name.
Right.
They burn out because their loved ones are wandering into the street at night, or not sleeping, or they're becoming agitated, or they're repetitively, agitated or aggressive. So it's often these treatable behavioral symptoms that are driving the burden of the illness that are, we can do something about that.
Sure.
To maximize quality of life and maintain safety.
And I think like any disease or illness, there's true benefits to early detection, right? You get better quality of life and better planning, better opportunities to plan.
And the other part of that, Sarah, which is a great point, is that increasingly, there's been this attitude, I think, in society. I feel like in some ways older people with depression and dementia are duly stigmatized. They're dealing with the stigma of ageism, where a lot of people project their own feelings about getting old, whether it's the loss, the infirmity. I mean, I just gave great stats from the CDC that the older folks are doing better mental health-wise. But if you ask most primary care clinicians and many community people, your loved ones, if you lost a loved one and you were getting older and you fell, broke your hip, wind up in a nursing home, well, I'd be depressed too. Well, maybe not. I wouldn't call depression normal aging. And sometimes we often think, well, if I were in that situation, that's the way I would feel. And that leads to kind of a closed-minded thinking about what we can do to help people. So that's one stigma. And then the second stigma is the stigma of mental illness, whether it's depression or whether it's a cognitive disorder like Alzheimer's disease. It's highly stigmatized. And I think in some ways that's why we don't do early detection. Why are we not screening everybody now in primary care all the time, early on, for cognitive problem? All right, we don't have a cure. Of course we don't have a cure, but there's so much we can do for people. And if we don't intervene early, we wind up dealing with crisis after crisis. There's so much prevention opportunity that's being missed. And in the future, and that future may be within our sights within the next 3 to 5 years, we're going to have medications on the market, I'm almost convinced, that will likely slow down the course of illness and improve quality of life, but only if we get people early enough. We know these treatments, which are antibodies that attack the underlying brain disease, these amyloid proteins in the brain, we know those are only effective if we get people prior to the onset of no longer being able to drive or no longer being able to pay their bills. Once you're at that stage, these particular medicines may not be as helpful, but earlier intervention might be quite instrumental. So we may be seeing some medications that are going to be reviewed by the FDA in the very near future that could come to market and make a big difference in terms of the importance of early intervention.
Wow,
It's
that's
so
awesome.
exciting.
That's good news. And that's actually a great segue for our next question would be, if someone feels like they're fairly healthy mental health wise, but wants to maintain wellness. Can you offer some suggestions that are helpful right now for people, some tips to maintain wellness, mental health wellness, and maybe when to seek assistance, from a professional?
Great question. So there's been a growing literature, so I'm not just making this up, on the benefits of some key lifestyle adaptations that we can all do to improve healthy brain aging. And this concept we call often successful aging, trying to maximize independence, success, and happiness with aging. So there are three main buckets that this falls into. One is we want to make sure that we are doing what's right in terms of our diet. So there's a lot of nutritional studies out there that have shown that certain dietary approaches that are very doable actually promote healthy brain aging. And those one common one is called the Mediterranean diet. But any diet that promotes foods that are rich in antioxidants, that reduce oxidative stress and promote the health of brain cells and, frankly, the organelles in cells called mitochondria that produce energy. Healthy brain aging, really, I think critical component is the Mediterranean diet. Antioxidant, green leafy vegetables, red wine's in there, by the way, but we want to minimize the use of that as much as possible. So a teeny bit, perhaps, but I'm always cautious about ever encouraging someone to drink wine. But there is something in like resveratrol. There are components of red wine that may be protective, but certainly diet is one. The second is exercise. And I think the data is the best in terms of brain health and exercise. And this has been demonstrated in both animal studies and in human studies. There seems to be a reduction in the buildup of amyloid plaque in the brain and tau proteins in the brain that are associated with dementia. People who exercise, generally speaking, it needs to be aerobic exercise. You don't have to train for a marathon. You can do 15 to 30 minutes of aerobic exercise 3 times a week and get your heart rate up. That can be wonderful. So there's nutrition, there's exercise. But the third thing that's critically important is social stimulation. Really important to engage with other people. And that can be hard in a pandemic. But there are ways to get around it, as we talked about, using technology and other kinds of ways. And now as people are getting vaccinated, hopefully this will become less of an issue. But social engagement and social engagement is really important to reduce social isolation, actually helps your brain. And I guess if I had to say the fourth thing would be, and there's literature on this, but this needs to be better developed, which is brain games. Challenging your brain with stimulating cognitive exercises. Now, not everybody's good at crossword puzzles. So this is not a one-size-fit-all type of thing. Some people are bad with language or memory, and you give them a crossword puzzle, and it's like a nightmare, and so that's not good enough. Other people might find Sudoku or other games too easy. So, you got to find the thing that's right for you. So there are bazillion apps out there. There are a number of companies that have been promoting them, but there's really no one that I would recommend, but I would say something that keeps you engaged and challenges you. If I give this same talk over and over again, that doesn't help my brain. You don't want to do the same thing. You want to do something new and different, but something that's like in that sweet spot about not being too hard, but not being too easy. So those are like maybe diet, exercise, social engagement, and cognitive challenge of the brain, I think are 4 sort of basic components of healthy brain aging.
And those things are doable right now. So
doable right now, in or not in a pandemic.
That's right. Well, those are really great tips, Dr. Forrester. And really, just in conclusion, and to wrap things up with you, would you be able to share a little bit about how you ended up doing the work that you do and, your why, so to say, if you don't mind?
The work that we're so very grateful for.
Exactly.
I get this question a lot, and I always give 2 answers. And by the way, you mentioned I'm the president of the American Association for Geriatric Psychiatry. So next Monday, I'm privileged to be giving a presidential address virtually to our entire healthcare, our entire field. And that's my introductory slide. Why am I doing this? And so
Wow.
I've given it a lot of thought over the years, you might imagine. So there are 2 reasons. One is more of a personal reason. I've always really appreciated older adults in my family, in particular my 2 grandmothers. They both were widowed in their late 60s. Both my grandfathers who died were physicians. They died relatively young at 67, both of heart disease. They went on to live another 23 to 24 years beyond their husbands and worked into their mid to late 80s and lived independently. And I loved hearing their stories about life in the dark ages. I used to think that life before color TV, everything was black and white. So they would tell me about everything that was going on in the black and the white days. I love history, and I love the stories that they told from their own experiences. So that was one thing. The second was, I saw in medical school, I really loved internal medicine, and I loved neurology. I loved the way the brain and the body connected. And then, of course, I was interested in people's emotional states and psychiatry. So as I went through my residency in psychiatry, the one area in psychiatry that pulls neurology, medicine, and psychiatry together is geriatric psychiatry. And intellectually, it made sense to me. But then when I went into the field, what I didn't realize at the time is that it also puts you in a role where you're essentially functioning like a primary care clinician for these individuals and their families, almost like an old-fashioned family doctor. They come to you with everything. You help them with diagnosing challenging conditions like Alzheimer's disease. You help them think about end-of-life care. You try to maximize their quality of life. They've got medical issues that you know are affecting their mental well-being. And if you don't treat their UTI, like you mentioned, Erica, or if you don't figure out they have COVID, you can't possibly help their psychiatric condition. So the interaction of psychiatry, neurology, and medicine is really the heart of geriatric psychiatry, the ability to care for people like a family doc over time. And then finally, and probably to me most importantly, is that you're also treating the whole person and their family. It's not just the patient. You treat everyone. If I see a person in my office or anywhere and I don't involve the family, I have no idea what's going on, or at least I don't have that other's perspective. So the family work to me has been so profoundly meaningful, and I know it makes a difference. So it's that combination of my personal history and then I think what I found in the field. I think the last thing I would say is for those people who might have an interest in healthcare, there's so much we don't know about how to care for older adults. The field of geriatric mental health research in some ways is in its infancy. We have a lot of data on certain things that do work, but there's so much we don't know. So much of what we do to help older people with medications or psychotherapies were never studied in 70, 80, 90-year-olds. They were studied in healthy 30 and 40-year-olds, especially the medications. And then we're extrapolating information from the young people to apply it to old people, thinking it's going to work the same, and it doesn't. Yeah. So we'll never have enough geriatricians. We'll never have enough geriatric psychiatrists to deal with the impending epidemic of Alzheimer's disease and also the increasing age of our baby boomers. So we're going to have to also educate our colleagues in the rest of medicine and the rest of healthcare on these issues that you both understand, but that are specific about aging. If we just leave it up to generalists who are never trained in treating older people, we're not going to have anybody to care for us or our loved ones as we get older. So I think part of what I love about this as well is educating my colleagues in the rest of medicine on how best to care for people as they age, because it is really a whole different story than caring for a young, healthy person.
And that really goes to the whole community. Our whole community has to be able to learn to be Alzheimer's friendly, which I know everybody's really working on. I know the impact you have had on our families at Bridges by Epic in Westford, and it has just been, it's
more than grateful.
Yeah, it's really been unbelievable. We love working with you and are so grateful for the work that you do around the world, really. So keep up the good work, Dr. Forrester.
And thank you so much for joining us and being a part of our Bridges to Community show, Dr. Forrester. It's been wonderful spending the afternoon with you. And thank you, everyone, for joining in and tuning in to our Bridges to Community show. And we hope to see you next time.
See you next time.
Take care.
Thank you.